All right, let's go ahead and get started. So welcome everybody. This is our sixth webinar for 2025 in the community webinar series, which this year is entitled Mastering Lewy Body Dementia Together. We are now halfway through the series for this year, so thank you for joining us today. My name is Keith Fargo. I'm the Director of Scientific Initiatives here at the Lewy Body Dementia Association. This year, we've been exploring a range of topics to help you better understand Lewy body dementia and its symptoms. Also to strengthen your ability to advocate for services and support, and to pick up new tools and techniques to help you live optimally. Slide 2, please. LBDA's mission is to optimize the quality of life for all those affected by Lewy body dementia. To do this, we accelerate awareness, advance research for early diagnosis and improved care, and provide comprehensive education and compassionate support. Next slide, please. A few technical items to review before I bring in our presenter today. So first of all, if you are looking for closed captioning, you can launch that by selecting Show Captions at the bottom of your Zoom toolbar, and you can do that at any time during the presentation. So again, that is the Show Captions option at the bottom of the toolbar. There's also a resources icon on that same Zoom toolbar that has links as well as downloadable resources to accompany today's session. If you'd like, you can print out the webinar worksheet that's included in the resources guide, and that'll help you get through today's information and how to apply it in your everyday life. We do encourage you, please submit questions throughout the presentation. And in order to do that, please make use of the Q&A icon. The Q&A icon is really where you're going to want to put questions for us rather than in the chat, because that allows us to find those questions quickly. And following today's presentation, we will address a few of those questions from the audience Q&A pool. We'll get through as many as time allows. My colleague Rose will occasionally be dropping links into the chat throughout the presentation today. And these links will also be in your email inbox in about 1 week from today as part of our post-webinar thank you email. So anything you don't catch today during the presentation, as far as those links go, you'll have access to those again through your email. This presentation is being recorded, and like I said, an email will be sent to those who registered with the link to view the recording in about 1 week, along with those other resource links. When you leave the session today, you're going to see a brief survey that's going to ask you for your feedback about today's presentation. We would greatly appreciate it if you would take a moment to please complete that survey. It really does help inform our content for the remainder of the year and also as we look ahead to 2026. Slide 4, please, Rose. Finally, you can keep on learning until our next webinar with our on-demand learning options. Recordings of all of our past webinars can be found on our YouTube channel, which is called LBDA TV. Slide 5, please. In addition to that, the Lewy Learning Center offers courses on a variety of topics that you can watch, rewatch, and share with friends and family. And so that's sort of a self-paced learning opportunity for you. Slide 6, please. You can also watch the film Spark about Robin Williams' battle with Lewy body dementia and other video offerings on our Mediflix channel. Slide 7, please. And please consider joining our social media channels so that you can hear about upcoming LBDA webinars and other programming. Slide 8, please. Finally, you can always find information at lbda.org for more information about the webinar series, other support needs, and anything else having to do with LBDA. So now I'm going to ask to learn a little bit more about who's with us in the audience today and what kind of experience you have with Lewy body dementia. So Rose is going to pop this survey up onto the screen. Bear with me just one moment. Oh, and it looks like people are already starting to fill this out. That's terrific. So the question here is, It's slightly different for those of you who are affected by Lewy. So people living with LBD and their care partners, slightly different from those who are joining us as healthcare providers, researchers, volunteers, or advocates. So the question is either how long have you been living with LBD if you're a care partner or a person with Lewy, or how long have you been treating, learning about, or advocating for Lewy if you're a healthcare provider or other researcher, person joining us from other nonprofit organizations, volunteers, etc. All right, looks like we've got some really good answers here. It looks like about 54% of people said 0 to 3 years, so a relatively new crowd. Although we do have about a third of the crowd who's with us today that is saying 4 to 8 years. And then a sizable portion, looks like here about 15% saying over 9 years, with a 5% actually being more than 15 years. Thank you for answering that. So I'm going to stop sharing that poll. Okay. Now we have another webinar poll. Thank you very much. And this question is going to be asking you about your level of knowledge with the topic of today's webinar. So for this question, you can choose between the topic is new to me, I know a little bit about this webinar topic, I'm very knowledgeable about today's webinar topic, or I consider myself an expert in today's webinar topic. All right, this is great. Okay, thank you all for responding. Getting about half of the group is saying the webinar topic is brand new. About half of the group is saying that they have a little bit of knowledge about the topic today. And then we have a small percentage saying they're either very knowledgeable about today's webinar topic. It's not showing up here on a blue bar, but we did have one person say they're an expert in today's webinar topic. So thank you for joining us today as well. And I'm going to go ahead and stop sharing those results. All right, thank you very much, Rose, for helping us through the polls. Now we're going to meet our presenter, and this is someone who you may recognize if you've attended a few of LBDA's community webinars. Julia Wood is an occupational therapist and international presenter specializing in Parkinson's disease and related dementias. She leads professional and community education at the Lewy Body Dementia Association, LBDA, and serves on multiple advisory boards, including the International Neuropalliative Care Society and Pennsylvania's Alzheimer's, Dementia, and Related Disorders Advisory Committee. Julia also contributes to clinical guidelines and training programs, co-authoring the very first AOTA practice guideline for adults with Parkinson's disease, and serving as faculty for LSVT BIG and the Parkinson's Foundation Team Training Program. Please use your reactions tab to give a warm welcome to Julia Wood, who's joining us on the other side of the stage today. Welcome, Julia.
Thank you so much, Keith, for the kind introduction and for getting us started. I appreciate you being here. Oh, you guys, thanks so much. All right, so I'm going to go ahead and share my screen so we can get started. I'm really excited to talk to you guys about this topic today. So let me get our correct view here. Excellent. Okay, so as Keith mentioned, my name's Julia Wood. I'm the Director of Professional and Community Education here. And today's topic, we are going to be talking about rolling with those neuropsychiatric challenges, right? Using the DICE method to manage neuropsychiatric symptoms in Lewy body dementia. And this is an approach very near and dear to my heart. The first article, I think in 2014 that came out that really outlined this approach came out about a year after I started at the University of Pennsylvania working with this population, and I found it to be such a game changer. So I'm really excited to introduce you all to this. All right, so our plan for today is just to kind of briefly review the symptoms of Lewy body dementia and what those neuropsychiatric symptoms are so that we're all kind of on the same page. And then we're going to review the basics of the DICE approach and talk about where you can find resources for how to engage with it. They've got a great website and some really amazing resources that you can utilize to get started with this. And then we're also going to talk about some strategies that really help to support communication and engagement in meaningful activities, which can also be really helpful in living with Lewy body dementia. All right, so this first slide, I doubt I have to explain to everyone, but we know that LBD is highly complex. So our Venn diagram here shows how it is meant to represent that, we know there are cognitive changes and impairments, right? Those changes to executive function and visuospatial function and attention. We know that these neuropsychiatric features a lot of times can be early on for people living with Lewy and can be really frustrating and challenging to live with. We know there can be changes to movement, right? Or those motor symptoms like tremor and rigidity and stiffness that can impact the ability to engage in daily tasks. And then, of course, those sleep challenges like REM sleep behavior disorder, sleep fragmentation, and insomnia. So, that difficulty falling asleep and staying asleep can really impact quality of life as well. And then those autonomic symptoms related to blood pressure and other body functions like bowel and bladder habits can really cause a lot of issues for families as well. And the most important thing I think to remember as we're starting to talk about managing and focusing on these neuropsychiatric symptoms is that they don't live in a vacuum or in a silo, right? So if someone's had a poor night's sleep or maybe their sleep cycles are off, that can potentially exacerbate these neuropsychiatric symptoms. If someone is having a lot of changes to their vision and visuospatial changes, which we've had webinars on in the past, that can impact some of these hallucinations as well. So it's important to note that even though we're focusing on kind of this one symptomatic target today, it's important to remember that all of these symptoms kind of interact and interplay with one another. So when we talk about neuropsychiatric symptoms, you'll notice here often what we're referring to are hallucinations. So where someone might believe they see something that's not actually there. These can be visual in nature, or most often visual, but they could also be involve hearing. So they might hear voices or hear sounds that aren't actually present. They may smell smells that aren't actually there, or taste things that aren't there, or feel a touch. So they can involve any or all of the senses. And there's some research that suggests that sometimes the auditory hallucinations will kind of interplay with the visual hallucinations. And if you think about it, that can really kind of make it feel more concrete to the person that it's actually happening if that very vivid visual hallucination starts to speak to them. That person they're seeing actually starts to talk. When we talk about delusions, these are those fixed false beliefs that aren't true, but a lot of times it's really hard for the person to understand that it's not really happening. And so these are often paranoid in nature. So the person may feel that their care partner or their family member is trying to steal from them, or maybe they're having an affair with someone. And, you as the care partner, like, with what time would I have this affair? You're doing so much to try to care for them. So these can be really frustrating for families to live with. Also, agitation can be a problem. So sometimes people can get a little adamant or upset about what they're seeing or perceiving, or even just in general, get a little agitated. And then anxiety, depression, and apathy can also be mood changes that can interact and impact those daily activities. And it's important to note that these are not uncommon for people living with Lewy. The research suggests that these symptoms really appear earlier and more frequently compared to other neurodegenerative diseases. And when we think about these behavioral disturbances, where someone starts to kind of act out based on these symptoms, these are highly prevalent. And research suggests that it affects about 40 to 60% of individuals living with LBD. And then this can become really complicated because we also know that people with LBD have a lot of sensitivities to medications. And unfortunately, many of these sensitivities can involve the drugs that we would typically use to treat these symptoms. So, a lot of your traditional antipsychotic medications like haloperidol or Haldol actually block dopamine and can be very dangerous or even potentially deadly for someone with Parkinson's disease or Lewy body dementia. And the condition that these can cause a lot of times is neuroleptic malignant syndrome. So we might see symptoms of a fever, more muscle rigidity, and this can even lead to kidney failure. So, really important that we think about other ways to address these symptoms when possible. And also, if you do have to start taking an antipsychotic medication to really track the side effects and the symptoms and communicate with your healthcare team about any changes that you might know. Also, even the medications that we might use to treat anxiety, those benzodiazepines, can sometimes worsen cognition or increase anxiety. So, this is an area where, a lot of times that communication and collaboration with your healthcare team becomes really important so that they can treat and manage the best way possible and also hopefully reduce the chance of some of these side effects occurring. So, what is the DICE approach? What am I talking about when I say this? Well, this was developed by, in my opinion, a brilliant psychiatrist named Dr. Helen Kales and her colleagues. And it comes, she notes here in a quote on their website. She said, out of the frustration with the status quo of sedating people with dementia for any type of quote behavior that was deemed unacceptable. So, just like many of you out there have noted and communicated with us that you find it really frustrating that a lot of times they want to give your family member these medications that can cause a lot of problems and just sedate them, this is what really bore this approach. And so it's an evidence-informed framework that helps you manage these behavioral symptoms and doesn't typically a lot of times make them completely go away. It's not curative, but it really can help with symptom management. And it empowers you as the care partner, I think, and as a partner with your person with Lewy to help assess these symptoms and then find responses that can be effective. And so we're going to break down each step here. And so the D in DICE, the step one, is to really describe. So in my clinical practice, what I look to if someone came in and said that, we're really having a lot of issues with hallucinations and delusions, then I wanted to get as much information from that care partner to describe these behaviors they're seeing as possible. And so a tip they give in this article that I've cited below here is to think about it like you're describing a movie that you watched in as much detail as possible. So really clearly describing the who, what, when, and where the behavior occurred. And you want to think about not just the physical environment, which could include, lighting, time of day, things in the room, but also the social environment. Who was present at the time that the behavior occurred? Was it a busy environment? Were there a lot of people around? Or maybe a family member that, that maybe there's not a great relationship with? And we always want to consider the perspective of the person with LBD as well. So, kind of what was their sense of what took place in the interaction? What did they perceive was going on? And then, of course, we want to look at the amount of distress that behavior caused just the person with LBD, but also the care partner. So, really trying to get that full blown picture. And so you'll notice I gave an example here of, a statement could be Dan becomes agitated, right? So Dan is the who. The what would be agitated. The when, you'll notice, is every evening around 6 p.m. And the where is in his living room. So we're really trying to think of all of those different factors. And then we could dig down even deeper with these as well. And so then the second step, which is the I in DICE, is for investigate. And a lot of times this is where we're going to have to collaborate with that healthcare provider, right? So they're going to have to look at different factors related to the person. So these could be medical, This could be the severity or the type of cognitive impairment that the individual is coping with. Like I said, different aspects of the environment, noise or clutter. We always want to consider these sensory changes too. We know that for our folks with LBD, a lot of times visual changes can be a problem, and as well as visuospatial changes, which are the brain's ability to kind of process that visual information, and that can contribute a lot. And then we also want to think about any unmet needs that the person might be experiencing. So maybe they're hungry or bored or, having some fear, or they're feeling, kind of like things have gotten out of control and they're feeling that loss of sense of control in their life. And then when we think about the environment, like I mentioned a moment ago, we also not just want to consider the physical things around them, but what was the social context around that behavior as well. And then also important to note that we want to think about our expectations as a care partner or caregiver. So sometimes, and this could be a family care partner or a paid caregiver who maybe has unrealistic expectations. And I find we see this a lot of times with Lewy body dementia where people don't understand those cognitive fluctuations, right? Where 1 minute Jim can put his shirt on all by himself and everything's fine. And maybe the next minute he doesn't even know how to start the task. And that doesn't mean he's faking it. That is a very common presentation that we see. So we want to really make sure that those expectations are accurate and aligned. And then we also want to consider cultural factors, and I'll get into those a little bit more in this next slide. So when we're thinking about the person, I think, and even, this is for the provider and then also for you as the care partner, have there been any recent changes in medications? So maybe a new medication was added in. Maybe there was a change to a dose of a medication, higher or lower. Maybe you're titrating off of a medication, so gradually taking that dose lower. Are you taking an over-the-counter medication, like for allergies? So sometimes those can be problematic as well. And then we want to think about any additional medical conditions that might be a problem. Very common, you guys, if you feel like things are going along, pretty normally and okay, and then all of a sudden everything takes that sudden downslide, often that can be some kind of an infection. And quite often a urinary tract infection can be a very common cause for that. So we might need to do some medical testing to see what's going on there. Of course, we want to consider the severity of the cognitive impairment and the different domains that are involved. So with executive dysfunction, which is following steps, sequencing, planning, if someone's trying to do a task, this can really impact their ability to follow those steps and complete that task if they're having a lot of changes in this cognitive domain. And then never underestimate the power of sleep. Often we see people with Lewy body dementia may get their sleep schedules really mixed up to where they start to sleep all day and then kind of be awake at night. Sleep hygiene refers to our behaviors around sleep. And one that I found was quite prevalent with my patients in the past was having a television in the bedroom and having that on all night long. And that can be really, really detrimental for our sleep. So we want to think about, having a nice, calm, comfortable sleeping environment. So then if we go to the center section of this table, we also want to think about the factors and kind of investigate these factors around the care partner. So, or like I said, a paid caregiver, maybe it's a home health aide or someone who's attending to care in like a long-term care setting. So what is their understanding of dementia? And I think especially Lewy body dementia, because we know how different and complex it is. And also, what is their understanding of the person with Lewy, that's that PWL, their abilities? So, sometimes people will think that, like I said, the person's just doing it to them, or they're doing it on purpose, or they could do it yesterday. And so I think it's really important that we kind of have an understanding of what's going on in some of those expectations. And communication style can be so important. And this is something to really think about. Often if we're rushed or maybe upset or sleep deprived yourself as the care partner or caregiver, maybe communication is coming off as overly critical. Or maybe you're just asking more complex questions that take a lot longer to process, or offering too many choices. And this can be a difficult thing sometimes when we're trying to navigate these issues. And of course, just like we want to think about, depression and mood for the person living with LBD, of course, for care partners or paid caregivers, their own stress, depression, anxiety can also play into how they're responding in these situations. And then, I learned in occupational therapy school a long time ago that a lot of times family and cultural context really trump everything. And these are very unique to your family and your situation. So sometimes people really don't want someone in their home. Right? They don't want a paid caregiver, or they don't want to talk about this or talk even about it with their care provider because they feel like they're airing their dirty laundry. Sometimes people have made a promise, maybe a care partner has said, I will always keep you at home. I will never place you in a facility. So a lot of times for us as providers, understanding these different contexts within your family can be really helpful in how we approach your ability to kind of solve and work around these issues. As I mentioned, that environment can be so important. So sometimes there might be too much stimulation, right? So clutter in the environment, a lot of noise. Think about maybe if you have a big family gathering, like a reunion or a holiday celebration, and now there's all these people and maybe children there that are making a lot more noise than usual. It could also be under stimulation. So maybe there's poor lighting. Maybe there's not very much stimulation in the environment. Or maybe there's, a lack of visual cues or things to really prompt them what they're doing. We know that with the visuospatial changes and some of the changes to the brain with Lewy body dementia, that wayfinding in the environment, even in the home, sometimes even just from going to the recliner to the bathroom, can be very problematic. And we want to look at daily routines can be so important for an individual to have a predictable daily routine. And that can be really comforting because then the individual knows what to expect. And then we'll talk about this, as you can imagine, as an occupational therapy. My jam is always getting people involved in pleasurable activities. Idle hands are the devil's plaything. And so the more that we can tap into those previous interests, preserved capabilities of the individual, things that they like to do and want to do, can really be helpful in navigating these situations. So the step 3, or that C in our dice, is to create. And this is really where that collaboration becomes so, so, so important. We want to make sure that we're addressing those physical problems, right? If we've had a change in medication or maybe a dosing regimen, we want to look at what those side effects are. Talk with your healthcare provider about that. Are there some other adjustments that maybe need to happen? And then we want to treat those infections, right? If someone has a urinary tract infection, going to need medication for that. We also want to look at dehydration. I found in my practice that the difficulty sometimes for people moving and getting to the toilet, they'll start to not drink as much because they don't want to have to go to the bathroom. Sometimes it's even difficulty managing getting pants or clothing up and down. So they start to not drink to avoid having to do the task. And if they're dehydrated, it's kissing cousin that is constipation. And that can be very painful and uncomfortable. So we want to really look at how to treat and approach all of these things to make sure that those physical symptoms are as well managed as possible. With the postural changes that we see with Lewy body dementia and the rigidity, sometimes people will have pain in their back, in their flexor muscles, in their knees and their joints. And so we want to talk about that and make sure that we're trying to optimize pain management as well. And we want to look a lot of times at the treatment regimen overall. and optimize those treatments. Are there medications that could be optimized? Do we maybe need some physical therapy, occupational therapy, some things like that to get someone moving or feeling a little better? And then last, but certainly not least, making sure that we address any sleep issues that can be going on. And like I said, that's not always adding in a medication for sleep. Sometimes that's looking at those behaviors around sleep and seeing what we can do to improve that. And then from there, we want to try to come up with these non-pharmacological interventions, so non-drug approaches where we can. So a lot of times this can involve education and support for the care partner, the caregiver, maybe in those realistic expectations or in communication styles, right? We want to try to simplify any task that the individual is doing. So making things as simple, straightforward, and stepwise as possible can reduce sometimes some agitation as well. And then we want to identify those meaningful activities for the person with LBD to do. So what can we do to help occupy their time? And then I know we keep talking about the environment, but we want to look at safety in the environment first and foremost and make sure that lighting is appropriate. We don't have obstacles that are maybe going to be a tripping hazard or maybe someone, interacting with a toaster or a light switch or something in a way that could be dangerous. And then with it, just like we're simplifying a task, often we want to simplify the environment too. So if there's a lot of clutter, a lot of obstacles, a lot of things in the way that could be distracting attention, we want to address those things too. So then lastly, once we've gone through, we've described what we're seeing, right? We've investigated the possible causes. We've kind of created some approaches to it. Last, we want to then evaluate and look at how's it working? And so a lot of times, we're going to work with that provider to kind of have them evaluate the success. And we've got to monitor how effective was the plan. Did it reduce the behaviors we were seeing? Is it safe? Were there any hazards that are coming up? Have there been any unexpected consequences? Like maybe you set up an activity in some way and it involved scissors and the individual got cut, just as an example. And then what adjustments have you made to the environment? Have you made changes to lighting? Have you maybe tidied up a little bit or organized things a little bit? And then you always want to go back and kind of adjust the strategies as needed so that you can try to improve. And also, of course, over time with the progression of the disease, we're going to have to kind of tweak those strategies. What worked one day might not work another day, and kind of continue to keep that process going. So some tips out there for care partners, I think, to really remember as you go into these, working on these symptoms and collaborating with your healthcare team, it's so important to remember that these behaviors are not intentional. And sometimes that can be really hard when you're in the throes of it. And I think also remembering how unpredictable Lewy body dementia is. Those cognitive fluctuations and those changes to executive function can really often require ongoing support from you as the care partner and even cues for task completion. And I'll give an example here where one time I had a patient that was having some of these issues, and one of his activities that he liked to do was play these board games. And so we decided that they were going to get categories so that when family and friends came over or neighbors, that they could play the game. And I get a call from the wife and she says, it didn't work. And I was like, what didn't work? And she's like, categories. She's like, the box came in and I set it next to him and he never even opened the box. Well, clearly he needed a little support for setting this up. It was really meant for him to play with others, not to do alone. And so a lot of times it's not that we can just put them to an activity and be done, but by engaging and investing and spending time with these activities and helping to cue, that can help reduce these symptoms and make life more calm and hopefully predictable overall. Another point here is, think about ways, collaborating with each other that you can kind of relax the rules. Like, Do you really need to shave or shower every day? If that's something that's maybe really difficult or really frustrating, or maybe we're just having a really tough day, maybe it's a day we skip it and let it go and kind of give it a pass there. And always important to really avoid confronting and trying to convince someone that the delusion's not real or the hallucination's not real. But I will say, as a caveat to that, sometimes folks with LBD have insights into their hallucinations and delusions. I think I've talked before about my friend with Parkinson's disease dementia who was coming over to our house, and our neighbor has this mobile sculpt van, which is like a mobile med spa that he uses. And my friend was concerned and said that he thought the van was following him for some reason. And so I asked him, I said, I'm pretty sure it's my neighbor's van. Would you want to go take a look at it? And he wasn't agitated or anything. So I'm not saying if someone's agitated or upset to try this. And he said, yeah, let's go look at it. And so we scanned the QR code that was on the side of the van, and this menu popped up of these different treatments that you could get. And a lot of them were kind of that cool sculpting or things for like your body. And so we kind of got a laugh that I was like, well, if this van's following you around, they must think you need to get some work done. And so after that, he called it the butt van. So he would see it and laugh and say, there's the butt van. And so these are some things where sometimes you can talk it through. If the person's not upset or agitated, you can kind of get an idea of what they're thinking and why and how to approach it. We want to be very careful not to argue or confront. And then it's so important as a care partner. And I can hear the eyes rolling out there now. Try to find support for respite when possible, because you really do need that break time and that time to cut away for yourself so that you can have that energy to cope with these issues. And we're going to talk later about some ways that you can hopefully find some support. And then really, really necessary, find and utilize a support network. And I want to be clear, for some of you, that may mean a formal support group, right, that you go and participate in. But for some of you, it might just mean that you have some friends that you call and get together for coffee, or, talk about the way your life is going, or even just have kind of a phone pool. Support looks different for everyone. But whatever that looks like for you, really remember that you're going to need support to help you manage and cope with these symptoms. So those meaningful activities that we talked about, right? What does that mean? How do we do this? Well, you want to make sure that when you're trying to find an activity for the individual to do, that we want to think about what their preserved abilities are. So let's say they still have good dexterity with their hands, maybe, but maybe their vision's a little impacted. So we want to keep that in mind. So then it might be, trying to do a puzzle might not be the easiest thing to do. But we also want to think about their interest. What did they enjoy doing in the past? I had a gentleman, and one time that was a patient that loved to bake, and he couldn't really bake from scratch anymore, but he could use a baking mix, or they would get those slice and bake cookies, and he could slice those and bake them when the grandkids were coming over. And then also looking at aspects of the environment. So having a space set up for them to do these activities, any way that we can really enhance their ability to engage in whatever that activity is. You want to tap into as much as you can, those previous interest and current interest, to help promote that sense of self, even for someone with severe dementia. And you guys, and some of you may have said it, and it's okay, everybody gets a pass here. Nothing upsets me more than having someone say, well, they're not really there anymore. I promise you they are. It's our job to connect and reach out. I had a gentleman come in one time with severe dementia. I think he probably had, comorbid Alzheimer's pathology as well. His MoCA, which is usually a 30, right, was less than 10. And he would just sit and kind of stare. And his wife was so upset and didn't know what to do. And so I asked her, I said, what kind of things did he enjoy in his life? What really was his jam? What got him excited? And she said he always loved classic cars, especially Corvettes. So I literally just pulled up pictures of cars and put that in front of him, and up the eyes went. And he started engaging, and he was able to show me the type of Corvette he had had when he was 16, the first one he got, different cars that he liked, by pointing. So really, really try to find those connections and connect to that individual. But of course, when doing this, we want to consider the stage of the disease that they're at when we're choosing that activity design and how to set up that activity. And I'm going to go into that a little bit more in a second. And then we want to think about our cueing techniques and how we're supporting the individual. So looking at some strategies for how to cue. A lot of times for my care partners, what I would educate and help them understand is there could be a 20 to 30-second processing speed sometimes. So if I give you a cue, okay, honey, scoot forward to the edge of the chair, and then the person doesn't do it immediately. Okay, honey, I need you to scoot forward. Okay, scoot forward to the edge of the chair. It's like every single time we've clicked a window open in the computer. So we want to give that cue and kind of wait and give time for that response and time for that processing. We also want to consider the time of day to introduce these activities. If you know that your loved ones or your family members' time that they really are upset, or maybe they're kind of groggy in the morning, or they tend to really be out of it, that's probably not the time to really introduce an activity. But also then if we know that maybe around, say, 6 o'clock, there's some sundowning or some issues that way, then we might want to introduce that activity a little before that. So maybe we can offset that time of day. So we want to think about, what is the best time of day, and when can we introduce that activity? And this was taken from a great research study, you guys, here by Laura Gitlin, is the Tailored Activities program that I'll talk about in a little while. And they looked at some of these considerations for how to choose these activities. So that information is available out there. And the same study looked at the characteristics of these activities. So they had 158 activity prescriptions for 56 families, and they looked at the cueing needs, how much assistance they needed to kind of get the task started, and how long the individual can engage with the activity. And as you all probably know, we don't have specific stages for Lewy body dementia, right? It's so individual. Everybody's symptoms are very different at when they present, and so we haven't been able to stage it. But you can kind of think if someone has kind of mild impact, they found that more complex arts and crafts or different types of cognitive games and activities were preferred. And they found that people could engage for about 28 minutes. And you'll notice there they needed cueing about 70% of the time. So this might be a target for you, but it might be a little different too. Maybe you can engage a little longer, a little shorter. You'll notice the next one, we go to kind of more of a moderate music and entertainment. And kind of domestic and homemaking tasks. So maybe folding laundry or sorting items or putting things away or listening to music, watching movies and films. And they found that people can engage for about 24 minutes of activity. And they needed cues, though, almost 80% of the time. So this is where we talk about kind of that buy-in and that support. For severe dementia, they found that simple physical exercises, and we have a great course on our Lewy Learning Center with some really simple physical exercises in our course called Empowerment Through Education. That might be a great resource for you to use. And you might use the video so you can help lead the exercises. If your family member is having a hard time following on the screen, a lot of times they need that person in front of them to kind of guide. But you can also do maybe some different sensory activities or sorting or manipulation of objects. And they found here, you'll notice the time dropped significantly. So only about 15 minutes were they able to engage in an activity. And again, they needed that cueing about 80% of the time. So this kind of gives you hopefully an idea of some realistic expectations when you're trying to do those meaningful activities of how to approach them. So we talked a lot about communication, right, and how important this is as part of this approach. And like I mentioned earlier, it's so important to allow sufficient time for the person with LBD to respond to your cue or to your question. So remember, I used to take an egg timer, those that you could flip, and I had one that was 30 seconds. And a lot of times I would give those to my care partners, and then they'd know they'd give a cue, flip the timer, and wait and kind of see. So not over queuing. And then we want to try to keep those commands or those cues as simple, and one or two steps is as much as we want to try to do at once. Tone of voice can be so important. We want to try to keep our tone of voice calm and very reassuring, and really think about how our voice is maybe affecting that individual. Sometimes tactile cues like a touch can help to calm or direct or redirect an individual. And then if we're giving choices, like let's say it's lunchtime and, what do you want for lunch? That's a pretty open-ended question. I have to admit, I got off an airplane the other night. My husband asked me what I wanted for dinner, and I was like, give me two choices. So I felt like I was there as well. Because it's, easier to be like, would you like pasta or would you like chicken? Than just what would you like? And then sometimes we might have to help the individual with word finding, because it can be kind of difficult sometimes for them to come up with the word that they're trying to use or communicate. And this is where our speech language pathology colleagues can be really helpful in kind of helping with those communication strategies. So looking at some ways to adapt activities that are so important. I mentioned, once we kind of find these different approaches, you've got your DICE plan, right? You've got it going. Think of how we can get a consistent, familiar routine established. And then if we're going from, say, a pleasurable activity into maybe taking a shower, think of how we can gradually transition to that next activity. And sometimes music can be a great way to support that transition. So I had a gentleman that really did not like taking a shower, and we get a little agitated with that. And we found that when we had the temperature up in the bathroom to where it was much warmer, and he had a nice warm robe to wear, and we also played his favorite opera, then he'd go right in and get ready for that shower. So playing around with some things like that. It's important to schedule contact with family and friends. This might be having them come over, maybe doing some video chats, maybe some phone calls. So trying to keep some engagement there. And then, as I mentioned, create those special spaces for these activities and hobbies to occur where things are very clearly laid out, very clutter free, very inviting. So the person wants to go and engage in that hobby. And then to help with that too, keeping their belongings or the things that they like to do in a predictable, familiar place where they can find that item can be helpful. And then sometimes marking the item with pictures so that they know then what's inside. And I've talked to you guys before about how I had to learn the hard way when I would go from some of my patients with Alzheimer's, and sometimes I could put like just a little picture icon, right, of a sock on the drawer, and then they could find the sock drawer. My friend with Parkinson's disease dementia, we had to take a picture of the inside of his drawer to put on the outside of the drawer so he knew what was inside. So sometimes you have to play around and be creative. We already talked about breaking those tasks into steps, and maybe just approaching one step at a time, right? And cueing each of those steps. And then working to really decrease not just clutter in the environment, but also distractions. So sometimes having the television on all the time or the radio on in the background can be very distracting. And then simplify that environment as much as possible. Try to keep the clutter down, keep the light well, really think about how you can make the environment supportive as possible. So some additional tips here for success. I think be really patient and flexible, not just with the individual with Lewy, but also with yourself. One day what works might not work the next day. And that doesn't mean you failed or that you did anything wrong. It's just the nature of the beast. And to help this, sometimes keeping a behavior journal can be helpful. So, kind of what the behavior was and then what the responses were around it. So, what kind of helped to tone it down a little bit? What types of adjustments were supportive? And then getting that support from professionals and even from your peer groups. So, a lot of times you're going to have to talk with your doctor, like we said, about those medication management things. But also, psychiatrists and psychologists can be such a great support for working through strategies like DICE, social workers, certified dementia practitioners. So, who can you find that can support you and really help you and help answer your questions? And never underestimate the power of peer support. So, like I said, those support groups, or maybe even just friends or family, or, maybe you have a book club group that you've always looked to. And then, so important here, and I can hear the eye roll again because I know how difficult this is. Try to practice self-care for yourself, of course, and really look at your own, anxiety and depression and stress. And self-compassion is a practice by Dr. Kristen Neff that I encourage everyone, whether you have Lewy or you're a care partner or not. Myself, I try to work on self-compassion a lot because it really is learning to forgive ourselves for the times that we feel that we misstep or fail, and approach that in a different way. And I think last but certainly not least here, give yourself grace. This can be really hard. It can be a very difficult journey, and allowing yourself, the permission to not be perfect and to make mistakes or to not know what to do is very, very necessary. All right. And there's a lot of resources out there, you guys. We will be sending these out as well in a sheet for you, to kind of access these. The DICE Approach website is beautiful. You can sign up on there to get a worksheet to kind of help guide you through this. They have a fantastic manual that you can order that I heard from the founders that's being revised currently and will be available again soon. So they don't have it right now, but it will be available in the near future. Also, as I mentioned, on the Lewy Learning Center, we have our Unpacking Psychiatric Symptoms course that can help you if you're trying to understand these symptoms more. We also have a great course by an occupational therapist, Rachel Wiley, called Supporting Meaningful Engagement, that I encourage you to check out because she has a lot of practical suggestions on how to support these meaningful activities, be it shaving or doing ADL tasks, those activities of daily living, or engaging in more leisure activities. And then if we can support you in any way, our Lewy line is here to help. You can call them at 1-800-539-9767, or you can email support@lbda.org. And this could be if you want to find that social worker or psychologist or OT in your area to help you implement this DICE method, or maybe you're looking for that peer group and you're not sure where to start. And then I wanted to give a little shout out here for professionals in the audience. I really recommend that you get some training in the Tailored Activities Program by Dr. Laura Gitlin, who is also involved in DICE. And they have a great course at Drexel University where you can get more education on that. And then this is such an amazing resource here, you guys. The Persevere study. So this is a peer mentoring support and caregiver education program that is currently recruiting out of Rush University. I see some hearts floating up. We've got some people in Persevere. Thank you. And so it's an NIH funded study here for family caregivers of people with Parkinson's or Lewy body disease. They recruit either current or past family caregivers, and you receive weekly disease-specific practical guidance through a 12-week curriculum and resources and activities. And they match you, so they match experienced caregivers, right? So people who had more than 3 years of caregiving, or maybe they're a former care partner. And then you're trained as a mentor to support caregivers who are earlier along in their journey. And all participation is virtual. They do some surveys. And so you'll notice here we've got the link that we'll share out with you, and the QR code you can scan. But I really encourage each and every one, if you're looking for some peer support and mentoring, this is a great program. Our dear friend, Dr. Jori Fleisher, is the PI on this study, and she is a lovely individual and does such a great job with this program. All right, with that, I just want to sum up in some key points and then we'll take some questions. So you remember our DICE method was that describe, investigate, create, and evaluate. And that's a step-by-step framework to assess and address those neuropsychiatric symptoms. And so it's to help you as the care partner and also clinicians out there to develop safer, individualized interventions that we can avoid sometimes those drug strategies. And then by using this method, the hope is that families and healthcare providers can identify these strategies and advocate for appropriate treatments. And then the DICE method really fosters collaboration between caregivers and clinicians, equipping families with those tools for communication, to help you advocate for effective care and also ultimately enhance your quality of life. And with that, I thank you very much for your time and attention, and I'll stop sharing my screen so we can take some questions. Oh, thank you guys.
Hey, I think we're both in the webinar now. Real good. All right, excellent. So thank you so much, Julia. That was a really great presentation today. So I actually want to look at this. We're already getting all the love from the
Well, you have to tell them.
the audience. Look at that. So I was going to ask people to use their reactions to say thank you, but it looks like they already are. So thanks for that, everybody. We are going to go ahead and take some questions now that we received during the presentation. And Julia, I'm going to start with a couple that are relatively just sort of basic factual questions, and then we'll go into some questions that are a little bit more challenging. So on the basic factual side, one person asked what the MoCA is, and I figured if one person was asking, probably more than one person wants to know.
Oh, absolutely. I should have unpacked that a little bit more. Thank you for asking. So MoCA stands for the Montreal Cognitive Assessment. And this is a common cognitive screen that looks at all different cognitive domains. So there is a section that looks at visuospatial function, a section on executive function, attention, word finding, memory. And it's important to note that for folks with Parkinson's disease and even Lewy, it's often more sensitive than the Mini-Mental, which is another screening test that can be done. So if you've ever gone in and they have you draw the line from letter to number or name different animals or draw a clock, you were probably doing the Montreal Cognitive Assessment. So thank you for the question.
Great, thanks, Julia. And then another person had a question here, which I think I can just address really quickly, if you don't mind, Julia. The question was, they wanted us to name some specific support groups, but I thought instead of naming the specific support groups, what we could do is just, Rose can pop into the chat for you a link to the page on lbda.org where you can search for support groups that are new to you. So Rose just popped that in. So if anyone's looking for a support group, please go to the chat, click on that link, and you'll be able to find one near you. Last I heard, we have 94 across the country. So hopefully one near you.
And you guys too, keep in mind, if you look on that and maybe you don't find what you're looking for, feel free to reach out to our support team, because they might be able to find something else in the area that might be relevant for you. But yeah, that's a great place to start.
Yeah, all right, great. So, all right, so now we'll get into some more kind of questions that are more focused on the topic of today's presentation. So one is more about the symptoms themselves rather than about DICE. But the question is, are these neuropsychiatric symptoms specific to LBD, or can other disorders present in a similar way?
Oh, that's a really good question. And so absolutely. We know that, with frontotemporal dementia, there is a behavioral variant of that type of dementia. So we do see a lot of behavioral symptoms. Now, a lot of times the behavioral symptoms might be slightly different than the ones we're seeing with Lewy. But definitely that can be an issue. And then also with Alzheimer's, some people have agitation or might have delusions or hallucinations. So definitely there can be different types of diseases that can lead to these symptoms. Great question.
Great, thank you. Here we got several questions about sort of when you're having challenges about kind of introducing this kind of technique or approach. So one person asked, can you talk about avoiding confrontation? It says, my father gets stuck in delusions of doom and gloom and won't let go of the delusion. So this person is asking about how to handle that while not creating a confrontation.
Right. So, when we're trying to avoid that confrontation, we definitely wouldn't want to say something, not that you are, like, Dad, here you go again. This is just you being doom and gloom, and it's all the same thing all the time. But what I want to rather do is just try to redirect. And redirection might be to a different activity or to a different space. So, and not saying this is the case for you, but I found that a lot of my patients, if they were very doom and gloom oriented, had the news on all the time, and that will definitely take you there. So maybe sometimes turning off the television, maybe let's go out for a walk. Maybe they like to bird watch. I know I had a lot of patients that love to watch birds. And maybe you can go and sit, and find a place to watch the birds outside. But a lot of times, just kind of a redirection rather than confronting the behavior, trying to find some way to kind of move toward a different activity or a different home or room in the home or different environment.
Great. And then thank you. Here's a question about a person who, they don't see the person they're providing care for, they don't see them every day. And so this is a question kind of about coordinating with others. And the question is, my husband lives in a memory care apartment. I have tried several times to declutter his closet and chest of drawers. However, he repeatedly clutters them up again, which frustrates him when he is looking for particular clothing items. And it also frustrates me in trying to help him find his socks, as an example, only to see that the sock drawer is full of everything except for socks. Do you have any suggestions for this kind of situation?
Absolutely. Well, the number one thing that you can do, and this might not be relevant to your situation, but I think a lot of times looking at, is it possible to kind of simplify the amount of items that he has? So, you might think about maybe he has 30 pairs of socks, I'm just throwing a number out there, but maybe he could get by with 10. So maybe that even just kind of taking down the number, and you could put those in some storage maybe and take them home. It doesn't mean you have to get rid of them, but maybe, taking down the number of items he's dealing with. Unfortunately, the next part of the answer may be really necessary and might be harder to have. It may be that he really needs cues and support for putting things away. And something that you might try, because maybe if he enjoys kind of decluttering and cleaning up, that might be something that, staff, if there are aides or CNAs, could kind of help with at points. Maybe the therapist, maybe occupational therapy could work on that with him. Something else you might try are if you have little, I'm trying to think of how to describe this. Like I want to go over and grab one out of my drawer, but I'm not going to do it. But like a drawer organizer or something, or like a little thing that he puts the socks or the item in, and then that goes inside the drawer. So sometimes that can help to have that little organizer then to stick in the proper place, and so it can make it a little bit easier. But the unfortunate side is he may need support and cues for being able to do that and not mess up the environment. But
Sounds like almost like you're describing kind of a silverware box that
yes,
you would have in the
yes.
drawer. So you're not just kind of, all the silverware in there neatly, but actually in their own locations within the drawer.
Exactly. That's a really great example.
So here's a tricky one, I think. So this person is asking about handling delusions and hallucinations that involve thoughts of, I guess the person is either seeing someone threatening in the home or has a delusion that there may be some kind of a threat present. So the question is, what are some ideas on how to handle delusions and hallucinations which involve physical harm and people in the home? So the person feels like there are people in the home who might be harming them. And the person said, when I tried distraction, then she feels like I do not care or like I'm blowing her off because these are scary delusions and hallucinations. Any thoughts about those kinds of situations?
I would say, and this is where we get into a place where, to medicate or not to medicate. That is the question, right? And if the hallucinations and delusions are coming to a point that maybe they're really causing the person a lot of upset or agitation, or you fear that they might either feel they're going to be harmed or maybe harm someone or themselves come to harm, this is a time to talk to the doctor about a possible medication intervention. So I think it's important to note, as much as we were talking about non-pharmacological management today, there are some medications out there that can be helpful. And so I'd encourage you to talk with your doctor about that. I think too, there can be a way to, kind of validate, and then see if you can distract. So, saying, I can tell mom that you're really upset and you're really, really worried about this. So, why don't we see if we feel a little bit better if we go into a different room and talk about it there. And sometimes moving them out of that environment even can kind of, lighten things up a little bit. But these can be really, really complicated, especially I'm hearing kind of a tinge of perseveration. It sounds like they're kind of looping and stuck on this and really fixated. And I think that's when we start to kind of have that conversation about, is there maybe a medication that could be helpful?
Yeah, thank you for that. So, like with any kind of therapeutic approach, there are going to be limitations, and not every approach will work for everything. And sometimes we do need medications, for sure. But it sounded like you also said, you can try validating before distracting. You can try moving to a new location, and that may be beneficial as well.
Absolutely.
All right. So let's see. This is a little less focused on today's topic, but I thought it might be of interest actually to you, Julia, specifically as someone, because I know that this is an interest of yours, vision in LBD. And the person asked, my husband got a diagnosis of low pressure glaucoma
Mhm.
because they couldn't figure out what was going on with his vision. Could this be a symptom of LBD?
I would.
I know that's requiring a little bit of speculation on our part, so we can't answer specific medical questions.
Absolutely. But I would say possibly, because one thing I will say, and there's a couple of webinars, if I'm not sure if you've seen them, but we had a webinar on vision recently. There's a course on our Lewy Learning Center on vision and Lewy. I think looking at that, because a lot of times optometrists might not be familiar with Lewy, and if they're seeing, so what can be confusing, and I'm not sure if that's what happened in this case, is the person might have 20/20 vision, say, but then they're having these visual problems and they're like, this makes no sense, because it's that processing piece. And once that signal goes into the brain, how that gets mixed up. Some things that you might consider, there are neuro-ophthalmologists. Not sure what area you live in. They're not the easiest to always find, but if you have an academic medical center around you, likely they have one. And these are neurologists who specialize in ophthalmology, and they can really help a lot of times with kind of understanding those different symptoms we see that aren't really just about the eye, but also about the eye and the brain and the visual brain dysfunction that we're seeing.
Great. Thanks for taking that small detour with me. I thought you would appreciate
I'll
that
always
question.
detour on vision.
Okay, so here's another one, and this is I also thought you might appreciate this question. While investigating changes in cognitive condition, why is a UTI so frequently or suspected rather as the culprit?
I'm going to be really honest. I wish we had a doctor on here because I'm not a physician, but I don't know how, like, the urinary tract and the brain connect with the gut brain axis, but it seems like there's a UTI brain axis. But we see this a lot where people have a urinary tract infection that it will really exacerbate symptoms and psychiatric symptoms. My own grandmother, one time when she was in a long-term care facility, she started having a lot of falls and all these issues. And I said, have they checked her for a UTI? It I'm sure maybe I would ask that question again when Dr. Fleisher is on next month, Dr. Jori Fleisher, because I know she talks about UTIs a lot and she can probably give a more educated and informed answer than I did. But it's definitely very, very common that if there's a severe change in function, there's some type of infection, and most often a urinary tract infection. So sorry, I didn't have a better answer for that.
No, honestly, I think that was a great answer, which is that UTIs commonly do cause changes in cognition. And so if a person has a sudden change in cognition, the doctor is probably not trying to ignore you or ignore your thoughts about what's causing it, as much as they're probably just trying to see, is there a very simple explanation that we could fix with some simple antibiotics? And if so, they don't want to miss that. So it's not about, not taking you seriously or not taking your partner seriously. It's more about just, is there something simple that will fix this? And if not, then we'll go on to the more complex things.
Absolutely.
Great. So let's see. I had one in here. Okay, this one's very interesting. So this person asks, my loved one is in an assisted living facility. Okay, so they're not with them there. And each morning, he awakens and believes that he has been sleeping in a cabin or a field or a garage. So having, delusions upon waking, or at least, misunderstandings upon waking. Sometimes he thinks that I am with him and unresponsive. This has been occurring frequently over the last few weeks. He has been tested and does not have an infection and has no medication changes. And it sounds like this persists for about 2 hours or so after he wakes up. And the question in this is, how do I deal with this kind of delusion, if it's a delusion, or coach his caregivers on how to deal with it? And they finish by saying he's afraid to sleep now. So it's a serious problem that they're having.
Yeah, once again, I think if this is impacting something like sleep, or if we're getting into safety, that's when we want to start to look at is there may be some type of a medical approach, or medication approach that we want to do. But I do think though, so I think discussing that with the doctor is important. And you guys, if you're looking for safer alternatives for those medications, if you go to our Diamond Lewy Management Toolkit in the neuropsychiatric section, it does talk about the meds to avoid and the safer alternatives for those medications. And so if you're worried that maybe your care team doesn't know what those are, that's a great resource to share with them. And then I do think though, if maybe he's not agitated in the morning when he wakes, sometimes, they can go along with it a little bit, as far as the if it's not harmful and maybe he thinks he's at a cabin, maybe we can just play along a little bit until he kind of comes out of it. I would also wonder though too if there's any type of like maybe when he wakes up in the morning and is having this experience, like if you maybe got him out of the environment, like maybe go for a little walk or even, just kind of get him into a different setting, or maybe open the window and look outside, or maybe have an activity to get him started with of some sort, maybe bring it in the newspaper and kind of talking about the news, or is there something that you could use to maybe kind of distract away from that in the morning? And I will say too, one of your comments reminds me of a story by Dr. Allison Applebaum, who was with us last November and presented, and her father had Lewy body dementia. And she said that one day she came home and he was so angry with her because he had hallucinated that she was sitting at the edge of his bed all day and that she wouldn't respond or talk to him. And so she had to really try to explain to him, that wasn't me. It was not me sitting there. You thought you saw me. And so depending on how much you feel like you can discuss this with your husband, maybe talking about, I think that maybe your brain's playing a trick on you. And it puts me there because you're missing me and I'm home missing you too. And then maybe you're, thinking you're at the cabin because that was a place that you love. So kind of maybe unpacking and talking about it a little bit and saying something like, I promise you, if I was here, of course I'm going to talk to you. I love you. I'm here for you. And I'm sorry that your brain is playing this trick on you, and you have to kind of weigh whether, once again, if he's agitated or upset, if that's going to be seen as a confrontation, or if he kind of recognizes and has that insight into, I think this might be a little off. So there's some different ways to kind of approach it. I think look at, can you change the environment? Can you, maybe give a little distracting task? And then also having that conversation. She said it took her a while to get her dad to believe that she hadn't been sitting on the edge of the bed and ignoring him all day long. But having that conversation, and I would definitely recommend to anyone on here that's looking for a great book about being a caregiver for somebody with Lewy, check out her book, Stand By Me by Dr. Allison Applebaum, because she has some great tips and suggestions in there as well for coping with some of these changes.
Thank you, Julia and Maz. And difficult questions, difficult topic, not easy. We know this won't be easy for people, and sometimes you'll have to try multiple approaches, etc. And please know that LBDA, we're here to support you. So please keep that Lewy line number, on your refrigerator or wherever it needs to be, and reach out for support when you need it, please. We
And you
are
guys, please understand, I wanted to say really quickly, please understand that when I give an answer like that, none of it may work, right? I'm not there. I'm not in your situation. I don't want to make it sound like I think this is easier. You just do these few things and it'll all be better. I'm trying to throw mud at the wall and see what sticks, but I know how difficult, like Dr. Fargo said, this can be, and trying to provide suggestions, but by no means do I think this is easy or simple.
So thank you so much again, Julia. We are unfortunately out of time. So for everybody who has joined us today, I would like to say thank you for joining us today. And also thank you to Julia Wood for her time and sharing her wisdom with us as well. Just a brief reminder, you are going to receive an email from us in about 1 week with the link for the recording of the presentation, as well as the resources and links that were mentioned in today's webinar. We do invite you to visit our landing page on our website to stay informed on our upcoming webinars and also to access past recordings. Rose is going to drop the link to that landing page in the chat now. Our next webinar, which is called Navigating the Twilight, Understanding the Advanced Stages of Lewy Body Dementia, is coming up on Wednesday, July 23rd, beginning at 2 p.m. Eastern Time. And I do know that we got several questions actually that we didn't get a chance to get to today about how Lewy changes in those later stages. So please do come back for that webinar, and that'll be a great time to ask those questions from an expert in what happens in the late stages of LBD. That's going to be Dr. Jori Fleisher, and she will be presenting that. Again, it's designed both for care partners and for individuals living with LBD. She's going to explore those advanced stages, delving into some of the complexities and challenges that come with this, what we know to be a progressive neurological disorder. And you're also going to get some practical advice to help you navigate that journey of advanced LBD with confidence and also with compassion. So you can actually register for that webinar right now, and Rose is going to drop a registration link into the chat, but you can also sign up through our website. So if you missed that link, not a problem at all. And then one last thing I'd like to say as we're about to drop off here, as soon as we stop the webinar, a survey will launch, and we do hope that you will take that survey because, as I mentioned, we really do take those seriously as we're designing this course. So thank you very much, and we look forward to seeing you in July.
Thank you.